We wanted to keep some interesting sessions in the afternoon, and we also wanted to give some kind of very interesting titles. Who could take that challenge other than Dr. Deepak Padmanabhan, right? First session, first one? Yes. He's going to tell us in which patients he would not be using what? He would not be using no blood thinners. He would not be using no blood thinners. Atrial fibrillation, in whom, if he argues saying that every atrial fibrillation should be given blood thinners, he should produce the data in support of it. So it will be very interesting to listen to a professor who has been trained not only in India but also in abroad. And I wanted to talk to him privately as to what made him to leave Mayo Clinic and come back to India. Dr. Deepak Padmanabhan for you. Thank you so much.
Thank you so much for the kind introduction. Always a pleasure to be here. And sir is right. I mean, this is counterintuitive to what you would want to do. There are only two things that prevent mortality in atrial fibrillation. The second is a recent one. The first is something that is well established. There have been studies where people comfortable with anticoagulation versus people not comfortable with anticoagulation have treated patients with atrial fibrillation across a big Medicare series, and patients died when anticoagulation was not started. So when not to start anticoagulation is a counterintuitive thought. But yes, it's an important question, particularly because we have to first know what is the need for anticoagulation, why do we give anticoagulation, what are the clear-cut contraindications, then go for the role of AHREs, what do you do about the bleeding, and is that new baby on the block, left atrial appendage occluder, actually a panacea, or is it just some hype that we are talking about? So how do you decide whether to anticoagulate someone? Anticoagulation is not based on the rhythm of atrial fibrillation. It is a requisite, but the decision to anticoagulate is based upon the risk of the patient to get a stroke from the atrial fibrillation. The most common marker or the set of markers that have been used, risk scores, has been the CHADS-S2 VASC score that drives the stroke risk. So you first make the diagnosis of atrial fibrillation with the ECG, not on history, not on physical examination, but on the ECG, then calculate the CHADS-S2 VASC. There are a couple of others that have come up recently, but not too much in clinical practice. This is standard. For India, I like to call it CHADS-S2, because it's really not possible for us to know whether there is an atherosclerotic plaque in the descending aorta for the VASC to work very well. So CHADS-S2. Bleeding scores are used to modify therapy, not veto therapy. Very important, because now bleeding scores are actually being used to implant left atrial appendage occluders. So we have to be very careful. Bleeding scores modify your therapy, they do not veto therapy. And luckily for my generation, DOACs are available. I would be much more scared and much more worried about starting anticoagulation if we were left only with warfarin. DOACs are there. They are incredibly safe drugs and should be, in appropriate clinical situations, drugs of choice without hesitation. But this is not the focus of my talk. The focus of my talk is when not to give these drugs. So, low stroke risk. As mentioned by CHADS-S2, no oral anticoagulation should be given. Men less than 65, no hypertension, no diabetes, no CHF. And in the diagnosis of CHF, there is no distinction between HFpEF and HFrEF. So making the diagnosis of HFpEF is also giving you anticoagulation. Stroke TIA, low risk. Annual stroke risk for these patients is less than 1% without oral anticoagulant agents. The number needed to treat to prevent one episode of stroke is very high. The bleeding risk may outweigh the benefit, therefore nothing to be given, no anticoagulation. If you have sex in women, 1, in males it's Chad's-Vasc of 0. No anticoagulation. No antiplatelets also to be given in that group. Now, this second problem, device detected atrial high rate episodes. Why we are worried about atrial high rate episodes on the devices that we are implanting increasingly these days? Because there is enough robust evidence to suggest that atrial high rate episodes will cause strokes. But the key underlying factor is the burden. If you have atrial high rate episodes less than 5 minutes of duration, the stroke risk, just like a Chad's S2 Vasc of 0 or 1, is very low. Do not anticoagulate. Continue surveillance. 6 to 24 hours, the risk is low. The evidence was basically calculated on the basis of the 2 trials, the NOAA AFNet and the Artesia trials. Apixaban decreased stroke, increased bleeding. The first line of the Hippocrates Oath is, first do no harm, primum nocere. You cannot have a prescription that causes more bleeding. Low Chad's S2, deferring OAC is very reasonable in this group because the data is mixed. If you have a Chad's S2 that is low, if you have 6 minutes to 24 hours burden of atrial fibrillation, and here is a small insight, do not let the device tell you it is atrial fibrillation. Take a look at the EGMs. For the purposes of the study, to increase patients into the trial, all device detected atrial high rate episodes were considered atrial fibrillation. Sometimes they are just atrial tachycardias. You really don't need any kind of anticoagulation for atrial tachycardias. And finally, you have to always have a shared decision making. Let me give you an example. Somebody has had a stroke and then you find AHRE of 6 minutes to 24 hours. You want to anticoagulate that patient. But somebody has no risk factors, freshly implanted pacemaker, AHRE of 2.5 minutes, you don't want to implant the pacemaker. In fact, in that patient, do the other important thing, which also has mortality benefit in atrial fibrillation, lifestyle interventions. Making sure your fat content in the body is low, making sure you're doing 210 minutes of exercise of medium to high intensity every week, that is more beneficial than us writing some medicines. This is the comparison of the Artesia and the NOAA AFNet 6 trial. What is critical is, these were trials which used different definitions of when to treat. And so they really can't be compared with each other. Their endpoints are somewhat similar, but they gave us contrasting views. That's why go back to clinical medicine, go back to the fact that you have the Chad's S2 score and use it in concert with talking to the patient. What you are doing here is, for the AHRE, as you can see very clearly, this is the only thing that entails you to get medications. All of this is a problem. All of this you do not know. Only when it is high risk do you want to give any kind of anticoagulation when you are between 6 minutes to 24 hours. Only after 24 hours there is definitive evidence that I am going to give anticoagulation even if there has not been clinical evidence. This probably can be extrapolated to the Apple Watches and the other kind of devices, wearables that are coming up these days. Still have to review it, but you would suspect the burden of atrial fibrillation would be much lower. Every episode can cause a stroke, but clinical medicine does not work that way. You have to figure out what is the competing risk of bleeding by the intervention that you are doing and then compare the two to decide which is the better thing to do. Leave it to chance or actually take matters in your hands. This is another big problem. After AF ablation, you do an AF ablation, anticoagulation will be off. No. OAC is based on stroke risk, not rhythm outcome. Again, do not stop just because somebody has told you AF ablation was very successful. Patient has not had a clinical episode of atrial fibrillation. No. It's determined only by the stroke risk, not by the presence or absence of AF that is documented after the original diagnosis has been made. Cardioversion, less than 12 hours, it's a low risk condition. Heparin at the procedure may suffice. Beyond 24 to 48 hours, you can follow standard rules. But absolute contraindications, active major bleeding, potential of active major bleeding, patients with oncological malignancies. There is a good dictum. If you find somebody without an evident reason for an atrial fibrillation, look around for a malignancy. In the first 6 months, there is a high incidence of malignancies that are detected when typical lone AF is being diagnosed. Just be careful about it. Recent ICH, especially when it is lobar or cerebral amyloidosis. Small bleeds, when your patient is elderly, look for them, especially in the face of increasing dementia. Severe thrombocytopenia, less than 50,000, severe hepatic failure with coagulopathy, definitely do not anticoagulate. The active major bleeding, suppose you have GI, GU, pulmonary sites, temporarily stop it, treat the source, reverse if needed, resume after stabilization, and you would be surprised how many of them are actually treatable today than 10 years ago. Do not jump to the left atrial appendage occluder, even though the patient has come collapsed with a GU ulcer where the hemoglobin was 5. It can be treated. Intracranial hemorrhage. The problem is early rebleed is very possible. Therefore, acute loss of OAC is important, especially if you have intracerebral lobar evaluations. Avoid it long term. This is where is the only thing where you seriously have to consider left atrial appendage occlusion as an alternative. Remember the NOAC and the warfarin trials. The benefit was in the brain bleeds and not in anything else. And if you already have the brain bleeds, you really don't want to chance your arm trying to do those things. Severe thrombocytopenia, reversible causes, non-pharmacologic alternatives, traditional transient things, but these are not long-term contraindications. Similarly, advanced liver disease, child 2C, DOACs are contraindicated. Coagulopathies, bleeding risk is high. Warfarin is unreliable and unsafe in these patients. Definitely should be not given. Consider no OAC. That is also an option. Remember, when you are doing a left atrial appendage occluder, you are putting a foreign body right there. And it is not no antiplatelets at beginning. It is 3 months of dual antiplatelet therapy to begin with, followed by maintenance antiplatelet therapy. So it's a very tricky thing that you're doing in somebody who is at a high risk for bleeds, and clopidogrel does cause bleeding, significant ones. Pregnancy. DOACs are contraindicated in pregnancy. Warfarin is teratogenic. Again, low CHAD score, no OAC. If needed, therapeutic low molecular weight heparin may be given. Infective endocarditis. Atrial fibrillation is common in these patients. Recent stroke or ICH risk, acutely avoid it. Later on, go ahead and restart it. Periprocedural, honestly speaking, there should be no reason to stop a DOAC periprocedurally. It's very safe, good cauterization, go for it, especially if it does not involve the genitourinary system where damage can happen very, very fast. These are not reasons to stop OAC. This is like a double negative. Falls alone, do not stop the DOAC. Age less than 65, do not stop. Look at the risk score. High Hasbled, you treat the high Hasbled. Do not stop the OAC. Treat BP, treat the ulcer, treat alcohol, treat medications to see if they are actually required. Address the modifiable risks. That's what the ACC tells us to do. Antiplatelet is not an alternative. Aspirin does not prevent atrial fibrillation mediated stroke. Dual antiplatelet agents are not equal to oral anticoagulation. Use OAC or nothing. It is okay to tell the patient, we cannot do anything. We really don't need to do something for them all the time. Avoid aspirin instead kind of practice. And finally, this is an ESC class 3 recommendation. You will do more harm, and primum nocere. Now, what is this concept of LAAO, left atrial appendage occlusion, when OAC is unsafe? It is only a 2A indication when there is an absolute contraindication for long-term anticoagulation. It reduces embolic risk without OAC. That's all it does. It probably has a signal towards reduced bleeds, but that was compared with warfarin. The DOAC trials do not show any significance. So, for LA appendage, the one thing we don't do is tell our surgeons to take it out. There is a class 1 indication that if your patient is undergoing cardiac surgery, has atrial fibrillation, has a need for anticoagulation based on the CHADS S2 score, you have to compel your surgeon to take out the left atrial appendage. Whichever way he wants to is his choice, but it's a class 1 indication with mortality benefit. Let that sink in. Taking it out has mortality benefit. So there is no question that your surgeon should come out of a surgery in a patient having atrial fibrillation with the left atrial appendage in situ. There is this new trend of using bioprosthetic valves in patients with valvular disease and the appendage is still left. It is a disastrous combination. LAAO percutaneously is still a 2A, and definitely it's only for a contraindication to long-term anticoagulation due to a non-reversible cause, and we just went through a couple of them. That's all that is non-reversible. Everything else you stop and restart. So, practical algorithm for use as I wind up my talk, and thanks for the time. Confirm the AF. It is not a clinical diagnosis. Confirm the context and score the risk. Commit yourself whether you want to give anticoagulation or not. Check if there are absolute contraindications. If it's a low risk, do not give anticoagulation. If it is uncertain, discuss or make a shared decision making. In summary, therefore, OAC has mortality benefit, and therefore you have to have an absolute reason to not give it. Left atrial appendage occlusion is not an alternative. Mortality benefit is good, and the threshold is much lower than what it has been historically. Absolute contraindications are ongoing bleeds, thrombocytopenia, intralobar hemorrhage, presence of child-2 scoring of grade 3 on hepatic encephalopathy. AHRE greater than 24 hours, definitely anticoagulate. 6 to 24 hours, we don't really know. Less than 6 hours, forget about it. Left atrial appendage removal during surgery is absolutely essential. Do not depend on anticoagulation to help you in the post-operative period. It causes more complications and more deaths. And finally, primary use of left atrial appendage occlusion percutaneously, the data is out there for everyone to take a look. It's probably not clear right now. We don't really know how much we are going to benefit. Thank you.
Thank you, Dr. Deepak. Wonderful. You can sit here. If you want to see the slides better, you can go there. Yeah, thank you.